You visit a doctor, perhaps a specialist you have seen for years. The office looks the same, the staff is familiar, and the care you receive is routine. But then the bill arrives, and with it, a confusing and often substantial extra charge labeled a facility fee. This is a fee that hospitals and their affiliated clinics add on top of the doctor's professional charges. It is not for the specific service you received, but rather for the privilege of receiving that service within a hospital-owned setting. These fees can appear for something as simple as a follow-up consultation, a standard X-ray, or even a telehealth appointment conducted from the comfort of your own home, leaving patients bewildered and financially strained. This practice has become increasingly common as more independent doctors' offices are bought by large hospital systems. When a hospital acquires a private practice, it often reclassifies the location as a hospital outpatient department. This simple change in designation allows the hospital to legally add a facility fee to every patient's bill. Suddenly, the same office visit you have had for years costs significantly more, not because the care changed, but because the ownership did. This fee acts as a catch-all charge, intended to cover the hospital's overhead costs. It is a separate billing item from the physician's fee, creating a two-part bill for what was once a single charge. Patients are often caught completely off guard by these charges. Imagine going for a routine ultrasound and receiving one bill from the radiologist who interpreted the image, and a second, often larger bill from the hospital just for using their room and equipment. These fees can range from a modest $15 to several $100s per visit, and many insurance plans do not fully cover them, pushing the cost directly onto the patient. There is little transparency. Patients are rarely informed about the fee before their appointment, only discovering it when the statement arrives in the mail weeks or months later, turning a predictable medical expense into a surprise financial burden. The logic behind these fees becomes even more questionable when they are applied to services that do not seem to require a hospital setting at all. Telehealth is a prime example. During a virtual visit, the patient is not physically present in the hospital, not using its electricity, and not occupying its space. Yet, if the doctor is employed by a hospital system, a facility fee can still be tacked onto the bill. This has led many to question the fairness and justification of a system where a charge for using a facility is applied even when no facility is actually used by the patient, highlighting a disconnect between billing practices and the reality of modern healthcare delivery. Hospital administrators and industry groups, like the American Hospital Association, argue that facility fees are not arbitrary markups, but a financial necessity for survival. They contend that these charges are crucial for covering the immense operational costs that are unique to hospitals. A hospital, they explain, must be ready for anything 24 hours a day, 7 days a week. This includes maintaining a disaster-ready emergency room, stocking expensive life-saving drugs and supplies, and having specialized equipment on standby. The revenue generated from facility fees, they claim, helps subsidize these essential but often unprofitable services, ensuring the entire community has access to critical care when it is needed most. Furthermore, hospitals point to the extensive network of personnel required to keep their doors open. The facility fee, they argue, contributes to the salaries of a wide range of employees beyond the doctors and nurses you see during your visit. This includes pharmacists, lab technicians, medical records staff, janitorial crews, and security guards. All of these roles are vital to maintaining a safe, clean, and functioning healthcare environment. Without the financial stream from these fees, hospitals maintain they would be forced to cut back on staff or services, which could compromise the quality and availability of patient care across the board, from routine procedures to emergency interventions. The government, to some extent, has sanctioned this practice. Federal regulations permit certified hospitals to bill these fees as a way to recoup the higher overhead costs associated with their outpatient departments, compared to independent physician offices. Hospitals argue this is fair because their outpatient clinics are held to higher regulatory standards, requiring more rigorous safety protocols and expensive accreditation processes. These added layers of oversight, while beneficial for patient safety, come with a significant price tag. The facility fee is presented as the mechanism that allows hospitals to meet these stringent requirements without operating at a financial loss on every routine patient visit. However, the justification becomes less clear when these fees are applied to routine, schedulable appointments in an office that looks no different from a private practice down the street. Critics and patient advocates are asking a simple question: why should a predictable follow-up visit for a chronic condition carry the same overhead charge as a complex procedure requiring specialized hospital resources? The defense from hospitals is that all parts of the system must financially support the whole. The revenue from the rheumatologist's office helps keep the emergency room open, creating a financial ecosystem where the routine subsidizes the critical, a model that is now facing intense scrutiny. For patients, the real-world impact of facility fees often materializes as a frustrating and expensive surprise. Consider the story of Carrie Green from Oregon, who shared her experience with state lawmakers. She went for a routine checkup with her rheumatologist, a doctor she had been seeing regularly. The visit was brief and straightforward, taking place in a standard medical office with no apparent special equipment. Sometime later, she received a bill that included an unexpected $92 charge from the hospital that owned the clinic. This facility fee was an unwelcome addition to her medical costs, a charge for simply sitting in a room that she never would have associated with a hospital. These stories are becoming increasingly common as an estimated 40% of doctors now work for hospitals rather than in private practice. This shift means millions of patients are being introduced to the confusing world of hospital billing for the first time. Another patient might go for a simple X-ray and expect a single manageable copay. Instead, they receive two separate bills. Media group: patient undergoing X-ray procedure in hospital, radiologist with patient in X-ray room, nurse preparing patient for X-ray at stock at distribute _equally, one from the radiologist for reading the image, and a second, often much larger, facility fee from the hospital for the use of the X-ray machine and the room. This billing structure is rarely explained up front, leaving patients feeling deceived and powerless when they try to dispute the charges. The frustration is compounded by the lack of transparency and logic. Healthcare experts like Maureen Hensley Quinn of the National Academy of State Health Policy have publicly questioned the rationale. Why, she asks, are these fees being applied to routine office visits that do not require any of the emergency preparedness that hospitals cite as a justification? Patients are left to wonder why their scheduled 15-minute blood pressure check should help pay for the hospital's readiness for a major disaster. This perceived disconnect between the service received and the fee charged erodes trust in the healthcare system and makes patients feel like they are being exploited by opaque billing practices. This issue is not just about isolated incidents, it represents a systemic problem that adds a significant financial barrier to care. When patients with chronic conditions face hundreds of dollars in extra fees each year just for their regular checkups, they may be forced to delay or skip necessary appointments. This can lead to worsening health outcomes and, ironically, more expensive emergency care down the line. The surprise bill for a simple visit is more than an annoyance. It is a symptom of a healthcare financing system that often prioritizes institutional revenue over patient affordability and clarity, placing the financial burden on those who are most vulnerable. In the face of growing patient complaints and a lack of federal action, a significant number of states are now taking matters into their own hands. As of 2025, an estimated 15 states are actively considering or advancing new legislation aimed at curbing the use of facility fees. These state-level initiatives represent a grassroots pushback against a billing practice that many view as predatory. Lawmakers are responding to the powerful testimony of their constituents, people like Carrie Green in Oregon, who have brought their surprise bills to the Capitol as evidence of a broken system. The goal of these new laws varies, but they generally aim to either ban the fees for certain types of care, or at the very least, require hospitals to provide clear upfront notice to patients. In Oregon, for example, lawmakers are debating a proposal that would ban hospitals from charging facility fees for simple consultation or follow-up visits. This targeted approach seeks to eliminate the most egregious uses of the fee, where patients are charged extra for what amounts to a conversation with their doctor in a standard office setting. The proposed law acknowledges the hospital's need for revenue, but draws a line, arguing that routine, non-procedural care should not be burdened with these additional costs. If passed, such a law would provide immediate financial relief to patients who require regular specialist visits to manage chronic illnesses. Connecticut offers a glimpse into what this future might look like, as it has already implemented a ban on facility fees for certain types of outpatient visits. State regulators there report a noticeable decrease in the number of patient complaints related to these specific charges since the law took effect. However, the overall impact remains complex. Dr. Deidre Gifford, a state regulator, has noted that while complaints are down, hospitals have still managed to increase their total revenue from facility fees each year. This suggests that hospitals may be compensating for the lost revenue by increasing the fees on other services not covered by the ban, effectively shifting the cost rather than eliminating it. Despite the challenges, this wave of state-level action signals a critical turning point in the debate over healthcare costs and transparency. As more states pass laws to regulate facility fees, they create a patchwork of patient protections across the country. This could eventually build enough momentum to pressure the federal government to establish a national standard. For patients, these reforms promise a future with fewer surprise bills and more predictable medical expenses. The fight is far from over, but the actions being taken today in state houses from Oregon to Connecticut offer a clear sign that the era of unchecked facility fees may be coming to an end.